Since 2012, we at KPJ Healthcare College has been working very hard, offering the courses that we offer, the new courses from the level of bachelor to master's, PhD, and also the medical specialist training program. We have successfully run the new healthcare bachelor programs. And I would like to highlight that we have successfully graduated the first batch on time. And this is a testimony of the hard work and quality teaching and training of the staff, academic staff, and also the hardworking students that we have.
Studying KPJUC with practices in KPJ hospitals has got me used to great facilities and technologies that shaped me to become a good physiotherapist.
Nursing has been our forte since we started the nursing school back in 1991 with a diploma in nursing. In 2014, we started our Bachelor of Nursing.
KPJUC has been here longer than my age, so I decided to pursue my dreams due to its good reputation and higher chance to get a job as soon as I graduated.
We are proud that in 2016, we have our first graduates of Masters in Nursing, which brings our nursing school to a higher level of education school for nursing. So our nursing school at KPJUC is now an elite group of nursing school that offer all level of nursing courses.
I am proud to say that I am the product of KPJUC that has brought me up to this level of achievement. I am serving the educations for nursing for 9 years in KPJ Healthcare University College, and I am now the principals of KPJ International College of Johor Bahru.
Once I complete my diploma study, I choose KPJUC is due to KPJUC have a higher chances of job as I graduate.
I would like to have a special mention on our Bachelor of Pharmacy. This program has been accredited by the Pharmacy Board of Malaysia in 2017. Meaning that our graduates are pharmacists that are recognized by the Pharmacy Board professionally. And what is unique about our program is that upon graduations, they will automatically be employed by KPJ hospitals to work as housemanship.
I finished my foundation in science, I decided to pursue my undergrad studies in corporate communication as this institution teaches me to always seek for knowledge.
Our main groundbreaking achievement that has made history, not only at KPJUC, but history in Malaysia, is our success in conducting the Masters of Medical Specialist program.
The KPJUC has actually helped me so much, given us support and also contributing to helping us to improve and success in becoming a ENT surgeon.
The reason why I joined here is to become the best radiographer and to deliver high quality in KPJ hospitals and institutions.
We are happy to note that we have a new additional college that's joining the KPJ Healthcare Group. That is the Malaysian College of Hospitality and Management, or in short, MCHM. This allows KPJ Education Group a wider a range of courses to be offered other than healthcare, because they are focused on hospitality and management courses.
Selepas 2 tahun setengah saya bekerja di Hospital KPJ Pasir Gudang, saya telah membuat keputusan sendiri. Saya membuka syarikat yang menggunakan base sebagai home physiotherapy service, di mana itu lagi mudahkan orang lain lah. Dan sekarang ni saya mempunyai physiotherapy center sendiri yang bernama Passionate Health and Welfare.
When I reflect back through my career path, I never dreamed to be where I am here now today, to become the CEO of KPJ Rawang Specialist Hospital. Now, more than 20 years has gone, and I'm still with KPJ because I feel that KPJ have made my dream come true.
Assalamualaikum and hello everyone. This is my pleasure to introduce a brand new initiative by KPJ Healthcare College. We are going to organize Clinico-Pathological Conference or CPC. We have CPC before, but this is the first time that we are organizing fully online. Well, not because of the pandemic, but I think CPC, between the many hospitals in KPJ ought to be done online to encourage more participation from our postgraduates and consultants from every hospital in the KPJ group. Our CPC to be organized by KPJ Healthcare College in collaboration with KPJ hospitals will be conducted every third Wednesday of the month for just 1 hour from 1 p.m. to 2 p.m. So, for 1 hour every third Wednesday to attend this CPC. Like most other CPC, we will have an interesting presentation of cases selected by the consultant and our postgraduate students, our senior registrar and our registrar, and we will try to choose cases that are requiring multidisciplinary approach in the management, rare cases, and thought-provoking way of managing some of these cases. So I'm sure you will find it interesting. So do attend the CPC that we're going to organize every third Wednesday of the month. Attendees to the CPC will obtain CPD point. So take this opportunity. Presenters will gain 5 CPD points, while attendees will gain 1 CPD points. I would like to thank Dr. Mawada and her team for organizing this CPC, and I'll certainly encourage all the postgraduate students. In fact, I would say I would make it compulsory for all the postgraduate students of KPJ College, the registrars and also senior registrars to attend this CPC. And certainly, I would like to invite and encourage our consultants, those who are supervisors of our master students or not. You are very much welcome to attend this CPC. I really hope this will be an interesting session where we'll have exchange of ideas, sharing of knowledge and skills in the management of our patients in the hospital. And this, I hope, will also be a platform between all the consultants in all the hospitals in the KPJ Specialist Hospital group. Thank you and welcome. Assalamualaikum and hello everyone. It is my pleasure to introduce a brand new initiative by KPJ Healthcare College. We are going to organize Clinico-Pathological Conference or CPC. We have CPC before, but this is the first time that we are organizing it fully online. Well, not because of the pandemic, but I think CPC, between the many hospitals in KPJ ought to be done online to encourage more participation from our postgraduates and consultants from every hospital in the KPJ group. Our CPC to be organized by KPJ Healthcare College in collaboration with KPJ hospitals will be conducted every third Wednesday of the month for just 1 hour from 2 p.m. So please spare your time for an hour every third Wednesday to attend this CPC. Like most other CPC, we will have an interesting presentation of cases selected by the consultant and our postgraduate students, our senior registrar and our registrar, and we will try to choose cases that are requiring multidisciplinary approach in the management, rare cases, and thought-provoking way of managing some of these cases. So I'm sure you will find it interesting. So do attend the CPC that we will organize every third Wednesday of the month. Attend this to the CPC will obtain CP point. So presenters will gain 5 CP points, while attendees will gain 1 CP points. I would like to thank the Mawat and her team for organizing this CPC, and I'll certainly encourage all the postgraduate students. In fact, I would say I would make it compulsory for all the postgraduate students of KPJ Damansara College, the registrars and also senior registrars to attend this CPC. And certainly, I would like to invite and encourage our consultants, those who are supervisors of our master students or not. You are very much welcome to attend this CPC. I really hope this will be an interesting session where we will have exchange of ideas, sharing of knowledge and skills in the management, all the consultants in all the hospitals in the KPJ Specialist Hospital group. Thank you and welcome.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi and very good afternoon. Thank you everyone for joining us in our first KPJ and KPJUC group webinar. Given the times that we are in, our CPCs, which I believe we usually hold in each hospital, or at least in most KPJ hospitals on a weekly or monthly basis, will now be held as webinars and in cooperation with KPJUC. So welcome to everyone and thank you for giving your time this afternoon. KPJ Damansara, of course, like most other KPJ hospitals, have had our own CPCs on a monthly and sometimes even fortnightly basis before this. So I guess it's time to share with everyone else. And next month and the month after, it will be the turn of other KPJ hospitals. We'd like to thank KPJUC for also partnering us in this. The one good thing, I guess, about the pandemic is the ascendancy of webinars. Yeah, everyone is a Zoom expert now. So one of the good things about having it online is that we can now share with other hospitals, and so can other hospitals share with us. So thank you again, Prof. Luqman and KPJUC for partnering the KPJ group of hospitals. So today, from KPJ Damansara, we will have two speakers, one of whom, Dr. Mawaddah, is our radiologist who's a graduate of KPJ UC with UKM, I believe, and Dr. Aziza, who's a trainee in ENT in the same master's program. We will also have supervision from Drs. Rizo Mahmood, our consultant otorhinolaryngologist, as well as Dr. Shazli Draman, consultant endocrinologist from KPJ Damansara. And we have today two pathologists with us, one from an external group. So thank you very much, Dr. Lee Bang Rom from Pantai Premier Pathology, as well as Dr. Heruni Talib from our own lab link. And they will be joining us as well. One housekeeping announcement that I've been asked to make is on attendance. So the QR code for attendance will be given at the end of the presentation. Yeah. Please scan that code for your attendance, and I believe also the CPD points. Yes, they will be available. One CPD point, yes, one CPD point. And in case any of you have a problem with the QR code, with the scanning of the QR code, a link for the attendance will be given in the chat box at the end of the case presentation for you to click on the link for your attendance, and then again the one CPD point. And questions can be put in the chat box. Because we only have an hour or so, unfortunately, we will be taking questions from the chat box rather than from hands raised in the meeting. Yeah, okay. Without further ado, I think I would like to get the first speaker to actually get us rolling today. It will be Dr. Mawaddah, our radiologist from KPJ Damansara. Over to you, Mawaddah.
I will start with my first case presentation for today. So, good afternoon, everyone. Thank you for participating in this first webinar Clinico-Pathological Conference 2021. I'm Dr. Mawaddah, radiologist from KPJ Damansara. So now I'll present our first case for today, a rare cause of back pain. This is a case of 38-year-old Malay male with no known medical illness. He's a chronic smoker for the past 16 years. He was presented to us with acute low back pain, which started while doing some gardening. No radiation to both lower limbs, no history of fall or trauma, no fever, weight loss or loss of appetite, no abdominal pain. On physical examination, he was alert. There's no neurological deficit, no spine tenderness or deformity. The straight leg raise test was negative. The blood pressure was 158/92 with pulse rate of 65. The lungs was clear, CVS dual rhythm, no murmur, and abdomen was soft, non-tender, and no palpable mass. He has a lot of multiple indurated erythematous plaque on trunk and limbs since 4 years ago, which increasing in size and numbers. This is the image of the skin lesion that the patient was having at that point of time. The patient underwent MRI lumbosacrospine due to the acute low back pain on 3rd of April 2020. These are the images in T2 and T1 sequences of the MRI lumbosacrospine in sagittal section, showing there are multiple hypointense lesions within the vertebral body which appear hypointense in T1 and T2 sequences. These are more of the lesion which appear hypointense in T1 and T2 scattered over the whole lumbar spine. This is the sagittal section of T2 stir and T1 post-contrast, showing the similar lesion which appear hyperintense in T2 stir sequence and vein enhancement in T1 post-contrast, as you can see in these images. This is the coronal section of the MRI lumbosacrospine in T2 and T1 post-contrast, showing enhancement in post-contrast sequences as well as hypointense in T2 sequence. These images, I wanted to show the hypointense lesion in the iliac bone over the left side in T2 sequences, which appear hypointense, as well as T1 post-contrast with enhancement in T2 post-contrast sequence. These are the images in diffusion with the images showing similar lesion with significant restricted in diffusion. These are the images in post-contrast T1 sequences at L4 level, showing there are several enhancing lesions within the vertebral body as well as the both pedicles. So besides the bone marrow changes in the MRI lumbosacrospine, the patient also had posterior disc bulge with central extrusion as seen here, causing significant stenosis of the spinal canal with bilateral exiting nerve root impingement, which may also contribute to the back pain that patient is having. So at this point of time, our diagnosis was either multiple myeloma or bony metastasis due to diffuse changes in the bone marrow. Thus, the patient underwent X-ray for skeletal survey. However, the X-ray are unremarkable except for one chest X-ray. So this is the chest X-ray done on the 7th of April 2020, showing there are thickened right paratracheal stripes on the right, as you can see here, indicating possibility of mediastinal lymphadenopathy. Thus, patient at that point of time underwent CT chest, abdomen, and pelvis to see any involvement of the lymph node. So this was the CT chest, abdomen, and pelvis done on the 7th of April 2020. This is axial section of the CT chest at the level of lower neck in mediastinal window, showing there are multiple enlarged supraclavicular lymph node with enhancing subcutaneous nodule, as you can see here. This is the axial section of the CT thorax in mediastinal window, showing there are multiple enhancing mediastinal lymph node, mainly at the prevascular region as well as the right paratracheal region. This is one section below, showing there are multiple enlarged mediastinal lymph node and right paratracheal lymph node as well as the subcutaneous nodule. On your right, this is an axial section. I wanted to show that there's one particular lymph node here with a central focal of calcification, as seen here. So this is the axial section of the CT abdomen of the same patient, showing there are multiple enlarged para-aortic lymph node as well as the aortocaval lymph node, with multiple enhancing subcutaneous nodule at the trunk, mainly at the posterior aspect, as well as the lateral and anterior aspect. This is the enlarged aortocaval lymph node as well as the para-aortic lymph node. These are the coronal section of the CT scan, showing multiple enlarged right paratracheal lymph node and also para-aortic lymph node. This is the largest lymph node actually at the subcarina region, and these are all the intra-abdominal lymph node, mainly at the para-aortic region. These are the lung window of the CT chest of the patient, showing absolutely normal lung parenchyma bilaterally, And these are the bone window of the CT scan of the patient, showing no suspicious bone lesion. There's no lytic or sclerotic bone lesion. So at this point of time, we are thinking more of either lymphoma or TB due to the lymph node changes in the mediastinum, in the intra-abdominal, as well as the skin changes. So in summary, for this case, the initial presentation was back pain with bone marrow changes only seen on MRI. Our differentials at that point of time was multiple myeloma or bone metastasis. Skeletal survey had shown that it's negative bone changes except for enlarged paratracheal lymph node in the chest X-ray. The CT chest, abdomen, and pelvis showed mediastinal and intra-abdominal lymphadenopathy with multiple subcutaneous nodules. At that point of time, our differential was either lymphoma or TB. So what's next? So we did some laboratory finding to confirm our diagnosis. The full blood count was unremarkable. The uric acid was very high. The rest of the renal profile was normal. The peripheral blood phlegm showed normal examination, no morphological abnormality with normal cancer marker. Slightly deranged in the lipid profile as well as the liver function test. The quantiferon TB gold in test tube was negative. And the serum protein studies showed mild polyclonal increase in gamma globulin consistent with chronic inflammation or infection. And the Benz-Jones protein for multiple myeloma was negative. Due to the young age and absence of the constitutional symptoms, a decision was made to biopsy the skin lesions for pathological confirmation. It is less invasive compared to biopsy of the mediastinal lymph node. We did the skin biopsy by our dermatologist, and we sent the sample to Pantai Premier Pathology. With that, I passed to Dr. Lee Bang Rom, our pathologist from from Pantai Premier Pathology, for further discussion about the tissue histopathological examination. On to you, Dr. Lee Bang Rom.
Thank you very much. Thank you very much, Dr. Madawa and team for the invitations. Can you see my screen? Clear, right? Okay, this is going to present the skin biopsy because they sent over the skin biopsy to me, right? Sorry. Okay. This is a hospital that I serve. Currently, I'm in Pantai Group. And this is the two skin biopsy that I received, quite a large skin biopsy here. One is an excision biopsy and the other one is a punch biopsy. To make these sessions a bit interesting, I share the so-called a little bit of advance on histology or anatomy. Can you see the screen here? We actually can scan the whole entire slide into sort of a digitized formats. As can you see here, the whole slide actually is like a Google map that you can zoom in and zoom out, and then share this information with others, colleagues for discussion and for education purposes. As you can see here just now, the excision biopsy shows the epidermis, dermis, and the subcutaneous fat there. At first glance, you'll notice that the multiple nodules in the dermis, a lot of nodules, and what these nodules are consisting of. On higher power, you can see that this actually composed of mainly all the granuloma, right? On higher power, you can see that they are epithelioid cells, right? With a lot of cytoplasm and very scanty lymphocyte infiltrations, right? So granuloma with very scanty lymphocyte infiltration. I will emphasize this term again. And you look at the epidermis, there's actually no epidermis atrophic scenes. There's no atypical lymphocyte scene because the clinical is look like a lymphoma or lymphoid infiltrations. So we try very hard to look for any evidence of lymphoid malignancy or not. Look like it's none. All this granuloma. And once you see granuloma, what you're thinking of? You're thinking of all the causes of granuloma. You can list down there. And the other features that I want to share to you is there's no necrosis. There's no necrosis, so unlikely to be TB. right? So this granuloma. And at the same time, with this pattern in our country, we had to first think of possible of leprosy. First diagnosis will be leprosy first. And we look carefully, there's no hypertrophic nerve bundle seen, right? And the second biopsy is a punch, which basically show the same morphology. You can see here, right? Epidermis, granuloma, and all deep inside there, right? Of course, we do some stain, we do some Zero-Nielsen stain. This pattern is remind me of leprosy. In our country, once you got a diagnosis of granuloma, first thing you think of is infective causes. And this pattern remind me of leprosy. And clinically, the clinicians say that it's unlikely leprosy, even though we do a white stain also, which shows it's negative as well, right? So what else? So these are the pictures that I show. And come back to the granuloma. The granuloma that you saw is this type, sarcoid type. As I mentioned to you, granuloma can be a few types. One is a tuberculous, one is the suburictive. And these are the typical features of tuberculous granuloma, which have a central necrosis of a giant cell and a lot of lymphocyte at the rim. Compared to the one that we saw just now, there's no lymphocyte. And this is proof to you that, and the message to take home from me to y'all is, this is a granuloma. We call it naked granuloma because no lymphocyte there. And this is a sarcoidal granuloma, right? Okay. Now come back to the causes of granuloma. How do you classify that? From standard textbook, you already know that, right? You can list down, right? So you exclude one by one. But for the real sub-experts and the real high hands, we actually can classify in such a way. See, from the skin, you can see that whether it's leprosy pattern or not, you have lichenoid pattern or not, or sarcoid pattern or not. And this one is typically of a sarcoid pattern. But of course, we rule other possibility like TB, infective, syphilis, leishmania, all that, which are unlikely. And therefore, this is my final diagnosis, right? Of course, before I put down my conclusions, now in year of 2021, we need some special stain or immunohistochemical stain. So CD138 is a specific stain for plasma cell multiple myeloma, so it's negative, so unlikely. CD68 is a positive for the macrophages granuloma, so it's really proof that this is a granuloma, right? PAS and Zero-Nielsen stain, no fungal body, no Acifas bacilli. So my conclusion at the time is dermal granulomatous lesion with no necrosis, so suggestive of cutaneous sarcoidosis with ball in red color, right? And I put a comment that advise other investigations to rule other infective causes. There's a more main concern. And the sarcoidosis is a diagnosis of exclusions. Throughout the years, I have seen a lot of number of cases of sarcoidosis. Just want to share with you one of the possibility that we can miss before we put down the legs on sarcoidosis is this variant, so-called T-cell lymphoma. We call it cutaneous T-cell lymphoma. We call it mycosis fungoides. They have one variant, so-called granulomatous flat skin, right? In these conditions, patients will have chronic eczema, and you look at the skin, it's very atrophied. And this tumor cell will form sort of a weird granuloma under the dermis and causing sort of a plug or nodules and becomes a flat skin. So that's why we call it granulomatous flat skins. I've seen 2 or 3 cases of this, which initially the respiratory treat as sarcoids, but eventually it's the full-blown of disease, and I made a conclusions of that. This is one of the case. You can see that it's a lot of granuloma, look exactly like the sarcoid, but if you look carefully, actually there's some atypical lymphocyte that infiltrate into the skin, right? Okay, so I pass over to the Mawada for further discussions and discuss about sarcoid disease. Thank you very much.
Thank you so much, Dr. Lee Bang-Rom, for the thorough explanation about tissue histopathological examination. So based on discussion with Dr. Lee Bang-Rom, we narrowed down the differential diagnosis based on the tissue histopathological examination as either T-cell lymphoma or sarcoidosis. However, T-cell lymphoma tend to have more chronic skin changes like eczema or fungal infection, which is not present at in this patient. A bit of case discussion. The final diagnosis was made, disseminated sarcoidosis with bone marrow, cutaneous and lymph node involvement was established. Vertebral sarcoidosis with pelvic bone and skin involvement is rare. Sarcoidosis is a systemic granulomatous disease of unknown etiology with a histopathological hallmark of non-causating granulomatous inflammation of the involved organ. Commonly, involvement of the lungs and lymph node are seen. Usually, patient with sarcoidosis is 90% lung changes, which can be perilymphatic nodules, any lung nodules, cavitation, or even consolidation like alveolar sarcoidosis. Less frequently involved organs include liver, spleen, eye, central nervous system, salivary gland, muscles, and bone. When osseous involvement is seen, it usually affects the long bones of the hand and feet, with a quoted radiographic prevalence of 1 to 13%. Vertebral involvement is exceedingly rare, with only several case reports in the published medical literature. A bit of epidemiology of sarcoidosis, usually the age of onset between 2nd through 4th decades of life, with female predominance, highest incidence in African Americans, Northern European Caucasians, and lower in Asian population. The most common vertebral levels involved, if localized, are the lower thoracic and upper lumbar spine. However, diffuse involvement of the vertebrae may also occur. Osseous sarcoidosis is usually found when involvement of the other organs have already established the diagnosis. Involvement of the axial skeleton is almost symptomatic, manifesting as back pain as in this patient. There is no typical MRI finding with regards to vertebral sarcoidosis. Lesions may be purely osteosclerotic, osteolytic, or mixed with variable patterns. This lesion may also extend to involve pedicles and epidural space. However, spinal cord and cauda equina involvement are rare. There is no clear guideline exists for the treatment of extrapulmonary sarcoidosis. Patients who have osseous involvement but asymptomatic may not require treatment, but for those with symptoms such as pain, stiffness, bone destruction, treatment should be started. Corticosteroids in low to moderate doses usually are effective, while simultaneously correcting any hypercalcemia if present. The clinical symptoms and even imaging findings may completely or partially resolve in 29% of patients receiving steroid therapy. For patients who are not responsive to steroids or who are not able to tolerate the side effects, other agents such as methotrexate, hydroxychloroquine, cyclophosphamide, or anti-TNF-alpha are available as alternative drugs of choice. So as conclusion, vertebral sarcoidosis is an extremely rare manifestation of the disease with scanty available medical literature. A combination of clinical, radiological, biochemical, and pathological diagnosis is needed for accurate diagnosis. Delay in reaching definitive diagnosis is not uncommon due to the non-specific features and overlapping characteristics with other diseases such as malignancy, multiple myeloma, lymphoma, and TB. As for our patient, he was lost to follow up and we didn't see him after this last CT scan in 2020. Disseminated sarcoidosis is when the inflammation occurs throughout the system. The hallmark of sarcoidosis is relapsing chronic inflammation will lead to fibrosis without treatment. Arriving at a diagnosis of sarcoidosis is not a straightforward process. A wide range of differential would need to be considered. Tissue histopathological examination is the gold standard for diagnosis, and differentiating between sarcoidosis and malignancy remains a challenge to this day. These are my references. With that, I end my slide presentation. Thank you so much. I pass back to our chairman, Dr. Shazli. On to you, Dr. Shazli.
Thank you, Mawada and Dr. Bode. So, very interesting case. I rarely see myself. So I think because of the time, we're going to progress to the next case. And you could see, if any question, please do key in the chat box there. and we will try to answer it at the end of the session. If it's not, anybody could try to answer the question. So at least we keep, we keep the question answered throughout the presentation. So for the next case, I would like to invite actually Dr. Aziza, which is our master trainee in ENT, to present the next case. Dr. Aziza.
Assalamualaikum and a great good afternoon to all the attending KPJ Healthcare Consultant. Today I'll be presenting CPC on behalf of KPJUC. My supervisor is Dr. Rizzo from DSH and I am Dr. Aziza, third year master student in ENT. Okay. So I'll be presenting my case. Mrs. R, 39 years old Chinese lady, presented with right mid facial swelling for the past 4 years. And the swelling initially, for the initial 3 years, was intermittent, hence it was ignored. In 2020, she noted the swelling has increased and the swelling was localized to the right pre-auricular region. However, it was painless. And she denies any neck swelling and there was no constitutional symptom and facial weakness. Prior to her visit to DSH, she had consulted 2 ENT surgeons in the private sector, and she was advised for conservative management. A fine needle aspiration cytology was carried out, and she was told that it was a benign tumor. Subsequently, she had self-referred herself to DSH for second opinion. Past history, she had undergone hemorrhoidectomy in 2017, preoperatively detected to have valve prolapse and treated conservatively. Family history, she has an aunt who was diagnosed with bone cancer and her cousin was diagnosed and passed away with brain tumor. So social history, she's married with one child, worked as a marketing manager, has no history of smoking, and she's a social drinker. On examination, she appeared well nourished, not cachextic, no facial asymmetry, swelling at the right parotid area, which is non-tender, firm, measuring about 2 × 2, mobile, and there's no any skin changes. Oral cavity examination, there's no any discharge at the Stenson duct opening. Neck examination, there's no palpable cervical lymph node. Breast and axilla is normal finding. Flexible nasopharyngeal laryngoscopy was done and it was normal finding. No other systemic examination was unremarkable. So our provisional diagnosis at this time is pleomorphic adenoma of right parotid gland. The second one is mucoepidermal carcinoma, adenocarcinoma, Warthin's tumor, and actinic cell carcinoma. Investigation carried out. Full blood count was taken and it was normal. FNAC from Colombia, Asia was done in August 2020 and is suggestive of pleomorphic adenoma. And a CT scan of neck is proceeded on the 17th of August 2020. So I'll pass to Dr. Mawada for the radiological findings.
Thank you so much, Dr. Aziza. So now I will present the CT neck of the patient. So this is the CT scan of the neck, the patient at the level of parotid gland, showing there is a well-defined rounded lesion at the superior pole of the right parotid gland, mainly at the superficial lobe. It has an enhancing wall with areas of hypodensity in the center, suggestive of central necrosis. These are one section below, showing that the similar lesion with area of central necrosis and some nodular wall thickening with significant enhancement. There is no calcification within. There is no infiltration of the surrounding structure. There is a clear fat plane seen with the right masseter muscle anteriorly, with the carotid space medially, and with the parapharyngeal space medially. These slides showing there are some sub-centimeter cervical lymph node at the level 2, measuring about 4 mm in millimeters. These are the coronal section showing the similar lesion with thickened nodular enhancement and as well as central necrosis. So at this point of time, our impression was right parotid gland tumor at the superior pole of the right parotid gland with suspicious features of malignancy such as central necrosis and nodular wall thickening. But there is no lymph node involvement at this point of time. So I pass back to you, Dr. Aziza, on to you.
Thank you, Dr. Mawada, for your explanation on the CT. Patient then proceeded with right subtotal parotidectomy on the 17th of August. The intraoperative finding shows there is cystic tumor at the superior pole of the parotid gland, and all the facial nerve was identified and preserved. I share with you the intraoperative picture. Patient is placed in supine position. This is the posterior surface. This is the anterior surface. This is the neck of the patient. This is the external ear. So as you can see, this is the upper pole of the parotid gland tissue. This is the suspicious part of the tumor that you can see. If you can appreciate, there is a glimpse of a facial nerve appreciated here. This is a close-up picture where the facial nerve and its branches is identified and preserved. Hence, the specimen is sent for HPE, and now I pass to the pathologist for presenting on the pathological finding.
Dr. Herni, on to you.
Okay, thank you. Good evening. Okay, sorry. I will okay, I will start with the presentation, sorry. Okay. Okay, I will start with the HPE reporting for these patients done in 2020. 39 years old Chinese lady presented with a clinical diagnosis was right parotid tumor, cystic, with history of progressive right parotid enlargement. Specimen received is right parotid tissue with tumor. So this is the specimen that we received in formalin. Parotid tissue measuring about 45 mm in largest dimension, and cut surface show this is the tumor located at the superior pole, which consists of circumscribed brownish tumor.
Henry, we can't see your slide.
Oh, is it? Sorry. Sorry, it's not showing, is it?
No, unfortunately no. Do you want us to play for you?
Sorry. I think boleh kejap. Okay. Did you see our is there, is it?
Yeah, it's loading. Yeah, okay.
Okay, sorry. Again, this okay. Just brief description of the tumor. So this is the tumor that we received in formalin. Consists of this parotid glands tissue with this nodular tumor over the superior pole. The total size, the maximum size is 45 millimeter, and cut surface showed this tumor measuring about 9 mm in largest dimension with thick fibrous pseudocapsule surrounding it and area of hemorrhage. It appears solid cystic in nature. This is the adjacent salivary gland tissue which appears normal. There is no evidence of infiltration. Okay, at this point of it's a salivary gland neoplasia, solid histologically, it shows solid papillary and confluent microcystic architecture configuration, monomorphic rounded epithelial cell component, microacini, but there is no evidence of lymphovascular aparioneural invasion. So this is the overview of the section, which you have this normal salivary gland tissue, and this is the tumor. It appears solid cystic with a lot of hemorrhage. This is the thick capsule that show in the radiological view earlier. So on higher magnification, if you can identify, this is the salivary gland acini with this thick capsule. This is area where there is some foreign body reaction with cholesterol cleft and all inflammatory infiltrates. Some areas of tumor with papillary configuration is seen over here. Okay. Basically, the tumor is solid compactness of tubules. This is tubules, compactness of tubules with areas of hemorrhage. On higher magnification, you can see the tubule contain this colloid-like material, as well as this eosinophilic vacuolated secretion within the lumen. Okay, this is the papillary configuration of the tumor. It is lined by this secretory epithelium with fairly uniform-looking round nuclei, prominent nucleoli, and abundant granular eosinophilic to some vacuolated cytoplasm. Occasional mitosis are there. This is another view at one area where you have this tubulocystic architecture, a lot of cystic gland with in between solidness of the tumor cells. Okay, preliminary findings. The histologic features favor the current working interpretations of secretory carcinoma. So, a differential diagnosis, this is one of the differential is actinic cell tumor lah. But we have to differentiate this with IC because both present with a secretory cytoplasm. And then another one is, which is unlikely, is mucoepidermal carcinoma because there is no squamous or mucoid goblet cell present. This also need to be proved by IEC study. Okay, so immunohistochemistry staining will perform for CK7, P63, CK56, S100, and mammaglobin with GCD-FP15. These two are actually a breast marker. So immunohistochemistry studies show CK7 are diffusely positive in tumor cells, including the solid papillary and as what we call cystic acina pattern. P63 marker, this will stain the myoepithelium as well as squamous if there is any squamous differentiation, which are negative in this case. CK56 also a marker for myoepithelial as well as squamous if there is any squamous differentiation, which are also negative. And S100s are diffusely positive within the tumor. This is mammaglobin. Again, this is a breast marker together with the GCD-FP15. These two are breast marker. Other than this is not hormonal, but this is the marker that you usually use to mark the epithelium of the breast tissue. So mammaglobin is positive, however GCD-FP15 is negative in this case. So in summary, the tumor cells are positive for CK7, S100 and mammaglobin, and negative for P63, CK56 and GCD-FP15. So the tumor histologic type with the immunophenotype of the tumor suggests a mammary analog secretory carcinoma. So just a brief histologically, mammary analog secretory carcinoma is a rare primary salivary gland tumor. Usually it harbors this ETV6 genetic rearrangement by molecular study. The reason why it called mammary analog because it has similar morphology and histochemical and molecular features as secretory carcinoma of breast. And a little bit on the secretory carcinoma of the breast. It's also a rare variant of invasive carcinoma of breast. Initially, it was reported in children, one of the commonest in children, but after some study, it shows that it also affects older patient, and even it is more in elder patient. So histologically, they presented with low-grade cytologic atypia, bland nuclei, low mitotic rate, and they are usually triple negative or focal weak ER positive in the hormonal study. Okay, with that, thank you.
Thank you so much, Dr. Herni. I pass back to Dr. Aziza for continuation of the presentation.
Thank you very much, Dr. Herni. After the HPE report, patient underwent completion of total parotidectomy with right selective dissection, where level 2, 3, and 4 is removed. Intraoperative finding, there is the deep loop removed and appear uninvolved. Level 2 lymph node was enlarged and firm inconsistency. On my discussion, memory analog secretory carcinoma of parotid gland, it is an exceedingly rare tumor. It is first described in 2010, where up to date, there is only less than 200 cases reported in literature. This tumor reported more prevalent in a male gender. The common site of tumor includes head and neck region, which includes parotid, submandibular gland, and also minor salivary gland. And recently, it is reported to be involved in the esophagus and also lung. It is described as asymptomatic, slow-growing tumor. It is categorized as low-grade malignant salivary tumor. Histological diagnosis is possible with FNAC. However, FNAC, it is simple and useful investigation, but only provides 90.9% sensitivity and 97.2% specificity. Hence, it is difficult to differentiate with other tumors. CT scan only provides information regarding the extension and location of the tumor. On discussion on the treatment, surgical excision is the mainstay of treatment. Completion total parotidectomy and neck dissection with facial nerve preservation was done for this patient. This tumor has been reported to have a tendency for cervical lymph node metastasis, which is high-grade transformation. A clear surgical margin are often difficult, thus total parotidectomy is advised. Post-operative radiography is recommended for cases with close or involved surgical margin, perineural or lymphovascular invasion, high-grade tumor, and cervical lymph node metastasis. These are my references. Thank you very much for your kind attention.
Thank you so much, Dr. Aziza. I will pass to Dr. Rizzo for any input regarding the presentation.
Assalamualaikum. We did a general review on this tumor. I think there's one case reported in Japan in 2020, 4 or 5 years ago. I think Dr. Faiz has more details. So the history is something like this, where the FNA shows there's a pleomorphic adenoma. They did a superficial parotidectomy, and then it came back as malignant memory carcinoma, and then they have to run in again and do a total parotidectomy with a neck dissection. So it's in line with what we did. The only thing is, when I first examined the patient, the location and the feel of the tumor doesn't feel like a pleomorphic. Usually, pleomorphic adenoma, it has to be around your earlobe, is something behind or slightly below your earlobe, and then it's fairly mobile. But this is my third case where I experienced a preauricular parotid enlargement that has been reported as a FNA, reported as a pleomorphic adenoma, and then when we did a superficial, it came back as malignant. The hassle is you have to go in again and do a complete parotidectomy, and it's not easy, because once you in terms of facial nerve identification will be difficult, and then chances are you're gonna injured the patient. But luckily for this patient, she has a weak facial nerve for a couple of weeks, and then it completely recovers after a month or so. So I wonder whether before, because since pleomorphic adenoma is the commonest tumor in the parotid gland, 9 out of 10 is, even if you're not a pathologist, if you report as pleomorphic adenoma, chances are you're gonna get it right. So I think for a clinician, if you give a bit more input on the location of the tumor, and then maybe if the radiologist can give an input whether there is a difference between pleomorphic and other malignant tumors, you do on the scan that can show that, so that it helps the pathologist to have a,
I think it's very, very difficult actually, because radiologically speaking, what we see is just a lesion, a mass. Unless it's very, very infiltrated, then we can probably say a lot more. But more often than not, it's actually very well defined, well circumscribed. You can see the capsule very well. So what we do is actually we give differentials, and I guess we just wait for the surgery and the histopathological findings. So it's always yeah, we have to be also very careful when we are reporting, because there's always this this possibility that it could actually be malignant. So I think usually working with Dr. Rizzo is actually extremely careful with what needs to be done, whether it's going to be extended surgery or just localized kind of thing. So I think we work together as a team, and yeah, with that, I think it's not that easy with imaging to just say that it's something infiltrative unless you can actually see the features. Thank you.
Dr. Rizzo, in your opinion, could it be like two pathology, either pleomorphic adenoma and malignancy, or any malignant transformation of the pleomorphic adenoma as reported earlier?
Okay, we have done, I've done these cases where it is suddenly reported as carcinoma X pleomorphic adenoma. So if there is a malignant transformation, usually the pathologist will be able to tell whether, what was the primary benign tumor that, metastasized, that they changed into a malignant one. But this is clearly a malignant tumor. I don't think it has, and you can't get two different tumors in the same gland. So it is like a double one, and it never happened.
If I can comment a little bit on the
session, we also have got the QR code on, and maybe Dr. Shastri would like to take over the Q&A, or Dr. Faisal is here as well. So we got all the 3 chairpersons around, and the speakers are around. Dr. Rizzo is around. So if there are any questions that you'd like us to answer to, we'll be happy to do that. Yeah.
I think just gonna comment, I think it's great to see 93 people in the whole KPJ group attending the meeting. Well done, everyone. I know sometimes, I know it's lunchtime, but normally it's lunch working hours for us to keep going, but thank you everyone for attending. Any question, there's one question we have there. What features on CT scan can we use to suggest a tumor likely to be benign or malignant?
I think we answered that just now. Unless, I think it can be very, very tough, really. I'm not sure whether any other radiologist would say something, but yeah, unless we can see infiltrative features, for us to just put our foot down and say this is malignant, it can be a little bit difficult, especially most parotid tumors are actually benign. Yeah, Dr. Rizzo? Most are benign.
90% is pleomorphic. So that's the reason why the FNA will always come back as pleomorphic.
Yeah, so
it's a no-brainer.
Yeah.
Just like
there's a question from Dr. Lebang. Do we prefer FNA or core biopsy for salivary gland lesions?
Okay, I've got another case which is also a preauricular parotid swelling, and then this patient was sent from SGMC. The parent refused to do FNA because the chances of getting a positive result for an FNA is quite slim. So we agreed to do a frozen section. We did a superficial pericardiectomy, we did a frozen section, and the frozen section came back as benign, so we just, stopped at superficial pericardiectomy. So eventually it came back as a benign lesion. So I think it's another way to go in cases where you think that this is not pleomorphic. Anything below or around the earlobe, chances are you're dealing with pleomorphic. Anything elsewhere, so you have to be careful because it could be other than pleomorphic.
Yeah, but I guess if you involve the deep lobe, then you'd be, suspicious of malignancy, right?
Even deep lobe sometimes we can get,
and nodes, of course, nodes.
Yeah.
If we talk about nodes, then
No, I'm talking about if you see from the scan, can you suggest that, whether the thickened capsule, or you get like what Dr. Mona said, the central necrosis, or the calcification. Whether there are these tweaks that suggest that we are not dealing with a benign growth. We're dealing with
the fact remains that because 90%,
this information we can feed it to the pathologist so that they can they can have a more general view before reviewing.
Thank you, Dr. Rizzo. The code is actually the link to our Google form, which we're going to get your info and then get you registered for the points. Yeah, we will register you guys for MMA points. So Dr. Rosman has questions. Dr. Rosman?
Yes, I want to ask. Dr. Rizzo said he has done 3 cases where it was reported as pleomorphic adenoma, and then after that the HP came back more nasty. Then he has done a superficial periodectomy and has to go back in again. I want to ask, physically, when you operate, does it look different, pleomorphic adenoma, than a malignant that you can actually go on and do a total periodectomy and not wait for the results and have to go back in again?
Okay, in principle, in any parotid tumor, what we do is you need to get a cuff. The definition of superficial periodectomy is we remove the pathologic tissue with a cuff of a normal tissue surrounding it. We don't want to break the capsules that when even in pleomorphic adenoma, when the capsule breaks, the tumor will residuals around this surgical bed, and they can come back with recurrence in a couple of years. So we cannot tell from macroscopically when we perform the surgery whether we are dealing with a malignant or with the benign tumor, because the fact that
that was the
normal parotid tissue surrounding
that was the question, whether physically you can tell it's more malignant that you can do a total without waiting for the
Right. I think there was a question from Dr. Aminuddin Amin Sain, is it? Did you want to ask something or comment?
Congratulations, Rizzo. Congratulations. Very good presentation and very good case and well managed. Well managed. I think it's brave of you to do all these things. And congratulations on the facial nerve. But the only thing is, the facial nerve, is it that? How do you know that it's involved or not? Is it not required to do a frozen section during the surgery, the second surgery?
Facial nerve on the first surgery was not involved, and so the completion parotidectomy was done. The fact that in all malignant parotid cases we need to do a complete, total parotidectomy. It's not because of the facial nerve was not involved. Even during the first, the nerve was not involved.
Next question from Dr. Lee Bang. Dr. Lee Bang?
Yeah, on behalf of the pathologists, especially Dr. Hernie, I would like to say something about the FNA. FNA for these lesions, which is a very low-grade carcinoma, can be very, very difficult to differentiate from the pleomorphic adenoma. So I have to say something first. Second thing is, I'm not sure your center whether some of you already request for core biopsy of the salivary gland lesions or not. That will maybe if your suspicious lesions which doesn't correlate with your FNA result, you might proceed with core biopsy. I found that some others ENT surgeon will request so, and of course that's frozen sections can be entertained. All right, thank you.
Yeah, go ahead.
The thing about consulting patients in cardiac surgery case. It's easy to get to consult them with facial cardiac, because chances are you're going to wake up with a normal facial movement. If you tell them that maybe you have to do a total cardiacectomy, and then chances are you're going to have a facial weakness for the next couple of weeks, that is not something that they like to hear. So we have to be dead sure that if they're dealing with carcinoma, then you need to perform the total cardiacectomy and inform the patient will be weak for a couple of weeks. It's not that simple. Sometimes I think if the pathologist is unsure of whether we are dealing with pleomorphic, then you might as well write down as this is inconclusive and we are not sure, so that we can be during our when we explain to the patient when we are taking consent, and we have that option of doing a total correction.
Okay, Dr. Leibang, question. We got two more questions. One from Dr. Leibang first. Yes, go ahead, Dr. Leibang.
No, I already asked my question. Sorry, thank you very much.
That's fine. The next one, Dr. Bakri. Yeah, Dr. Bakri has questions. Go ahead.
No, thanks.
No, thanks. Okay. Well answered.
Dr. Faisal has a question there. Can MRI help?
In what?
In a detection of malignancy of parotid gland.
I think we have to be very, very careful actually to call it malignant, because more than 90%, Dr. Rizzo, is benign. So I guess we always have that caution that maybe we look at the enhancement pattern or the infiltrative pattern, then I think we can be a little bit more when we report, I guess. But at the same time, we're always cautious about what we say, and we pass it to the ENT guys to sort it out, and of course the pathologist to finally come down and say, okay, it's malignant and not benign. So yeah, we can actually look for these features, but a lot of times I think we are also quite guarded about what we say in our report. So yeah, that's how it goes.
So there are also literature saying that MR imaging are the best to predict malignant potential in parotid gland tumors, especially low signal intensity in T2 sequences, as well as post-contrast ill-defined margin of parotid tumor are highly suggestive for malignancy, or even diffusion with the images are also may suggest of malignancy. So I guess that's all for the question.
Excellent. I think we got two very interesting, very rare cases that I think with the presentation, you'll see the reference at the end. I think they're ready to be published. They just put things together. You got the ingredients, short publication anyway. I think even the first one, New England short cases, which is very rare, even very rare tumor, less than 200 cases in the world. A short one that won't take much of your time to put this together. I think worth a try. I saw Dr. Lokman Simon as well. Any comment, Dr.?
Oh, thank you for the submission. I just want to congratulate the whole team from Damansara Specialist Hospital, KPJ, and our graduates and our master student, Dr. Aziz and Mawada, for very successful, first CPC, and I think we got good response from the whole group. Close to 100 people have attended this. So I just want to remind that the next one will be from orthopedic and surgery. So our supervisors and our postgraduate students be ready for your presentation next month, and we hope this will continue, in the coming months and years. Thank you, Dr. Azli. Thank you.
Okay, excellent. So with that, I think we just until 2 o'clock. So we're going to close the session. I would like to thank you all, the presenter, and also our two pathologists, Dr. Lee Bang Rom and Dr. Hani Talib. The next CPC will be on the 18th of August with Ampang 3, and then presentation by the trainee or the graduates. So thank you all. Thank you again. Assalamualaikum and very good afternoon.
Waalaikumsalam.
Yang